Jason S. Finkelstein, MD Cardiology Fellow, Tulane University, August 11, 2003. Aortic Dissection. Jason S. Finkelstein, MD. Cardiology Fellow. Tulane University. August 11, 2003. Overview. Incidence of aortic dissection is at least 2,000 new cases per year. Peak incidence is in the 6th to 7th decade. Men are affected twice as commonly as women. Mortality in the first 48 hours is 1% per hour. Early diagnosis is essential. Pathophysiology. The chief predisposing factor is degeneration of collagen and elastin in the aortic intimal media. Blood passes through the tear into the aortic media, separating the media from the intima and creating a false lumen. Dissection can occur both distal and proximal to the tear. Classification: DeBakey system, type I, type 2, type 3. Originates in the ascending aorta, propagates to the aortic arch and beyond it distally. Type 2. Confined to the ascending aorta. Type 3. Confined to the descending aorta, and extends distally, or rarely retrograde into the aortic arch. Classification: the Stanford system, type A, type B. All dissections involving the ascending aorta. Type B. All other dissections regardless of the site of the primary intimal tear. Ascending aortic dissections are twice as common as descending. Predisposing factors: age, 60 to 80 years old. Long-standing history of hypertension. 80% of cases have coexisting HTN. Takayasu's arteritis. Giant cell arteritis. Syphilis. Collagen disorders. Marfan syndrome, 6 to 9% of aortic dissections. Ehlers-Danlos syndrome. Other risk factors: congenital cardiac anomalies. Bicuspid aortic valve, 7 to 14% of cases. Coarctation of the aorta. Cocaine. Abrupt HTN, due to catecholamine release. Trauma. Pregnancy, 50% of dissections in women less than 40 years. Iatrogenic, cardiac cath, IAB, cardiac surgery, SP valve replacement. Clinical symptoms. Severe, sharp, tearing posterior chest pain or back pain, occurs in 74 to 90% of PTS. Pain may be associated with syncope, CVA, ME, or CHF. Painless dissection relatively uncommon. Chest pain is more common with type A dissections. Back or abdominal pain is more common with type B dissections. Physical exam: pulse deficit, acute aortic insufficiency. Weak or absent carotid, brachial, or femoral pulses. These patients have a higher rate of mortality. Acute aortic insufficiency. Diastolic decrescendo murmur. Best heard along the right sternal border. Clinical signs: acute knee cardiac tamponade, pleural effusions. RCA most commonly involved. Cardiac tamponade. Pleural effusions. Hypertension or hypotension. Hemothorax. Variation in BP between the arms, greater than 30 mm of mercury. Neurologic deficits. Stroke or decreased consciousness. Clinical signs: involvement of the descending aorta, splanchnic ischemia. Renal insufficiency. Lower extremity ischemia. Spinal cord ischemia. Diagnosis: generally suspected from the history and P. In a recent study in 2000, 96% of acute dissection patients could be identified based upon a combination of 3 clinical features. Immediate onset of chest pain. Mediastinal widening on CXR. A variation in pulse and/or blood pressure, greater than 20 mm of mercury difference between R and L arm. Incidence greater than 83% when any combination of all 3 variables occurs. Differential diagnosis. Acute coronary syndrome. Pericarditis. Pulmonary embolus. Pleuritis. Cholecystitis. Perforating ulcer. Diagnostic tests EKG CXR cardiac enzymes. Absence of EKG changes usually helps distinguish dissection from angina. Usually nonspecific STT wave changes seen. CXR. Cardiac enzymes. Chest X-ray. May show widening of the aorta with ascending aorta dissections. Present in 63% of patients with type A dissections. Diagnostic imaging not performed until the patient is medically stable. Has been a dramatic shift from invasive to non-invasive diagnostic strategy. Spiral CT scan. T. MRI. Angiography. Imaging can identify aortic dissection and other features such as involvement of the ascending aorta, extent of dissection, thrombus in the false lumen, branch vessel or coronary artery involvement, aortic insufficiency, pericardial effusion with or without tamponade, sites of entry and re-entry. Angiography, first definitive test for aortic dissection. Traditionally considered the gold standard. Involves injection of contrast media into the aorta. Identifies the site of the dissection. Major branches of the aorta. Communication site between true and false lumen. Can detect thrombus in the false lumen. Disadvantages. Not very practical in critically ill patients. Nephrotoxic contrast. Risks of an invasive procedure. Spiral CT sensitivity 83%, specificity 90 to 100%. Two distinct lumens with a visible intimal flap can be identified. Advantages. Non-invasive. Readily available at most hospitals on an emergency basis. Can differentiate dissection from other causes of aortic widening, tumor, periaortic hematoma, fat. Disadvantages. Sensitivity lower than T and MRI. Intimal flap is seen less than 75% of cases. Nephrotoxic contrast is required. Cannot reliably detect AI, or delineate branch vessels. TTE first used to diagnose aortic dissections in the 70s. Sensitivity 59 to 85%, specificity 63 to 96%. Image quality limited by obesity, lung disease, and chest wall deformities. T sensitivity 98%, specificity 95%. Advantages. Close proximity of the esophagus to the thoracic aorta. Portable procedure. Yields diagnosis in less than 5 minutes. Useful in patients too unstable for MRI. True and false lumens can be identified. Thrombosis, pericardial effusion, AI, and proximal coronary arteries can be readily visualized. T. Lower specificity attributed to reverberations, atherosclerotic vessels, or calcified aortic disease producing echo images that resemble an aortic flap. Disadvantages. Contraindicated in patients with esophageal varices, tumors, or strictures. Potential complications: bradycardia, hypotension, bronchospasm. MRI most accurate non-invasive for evaluating the thoracic aorta. Sensitivity 98%. Specificity 98%. Advantages. Safe. Can visualize the whole extent of the aorta in multiple planes. Ability to assess branch vessels, AI, and pericardial effusion. No contrast or radiation. Disadvantages. Not readily available on an emergency basis. Time consuming. Limited applicability in PTS with pacemakers or metallic clips. Conclusions. Conventional TTE is of limited diagnostic value in assessment of the thoracic aorta. Both T and MRI have excellent sensitivity, however MRI is more specific. MRI is the study of choice for stable patients. T is the study of choice for unstable patients. Treatment. Acute dissections involving the ascending aorta are considered surgical emergencies. Dissections confined to the descending aorta are treated medically. Unless patient demonstrates continued hemorrhage into the pleural or retroperitoneal space. Surgical options: excision of the intimal tier. Obliteration of entry into the false lumen proximally. Reconstitution of the aorta with interposition of a synthetic vascular graft. Type A dissections operative mortality varies from 7 to 35%. 27% post-op mortality. Patients who died had a higher rate of in-hospital complications such as strokes, renal failure, limb ischemia, and mesenteric ischemia. Poor prognostic factors. Hypotension or shock. Renal failure. Age 70 years. Pulse deficit. Prior ME. Underlying pulmonary disease. Preoperative neurologic impairment. Renal and/or visceral ischemia. Abnormal EKG, particularly ST elevation. Medical therapy. Reduce systolic BP to 100 to 120 mm of mercury or the lowest level that is tolerated. 4 beta blockers. Propranolol, 1 to 10 mg load, 3 mg per hour. Labetalol, 20 mg bolus, 0.5 to 2 mg per minute. If SBP remains greater than 100 mm of mercury, nitroprusside should be added. Do not use without beta blockade. Avoid hydralazine. Surgical intervention for type B dissections reserved for patients with a complicated course. Long-term outcome: type A type B survival at 5 years to 68%. Spontaneous healing of dissection is uncommon.